Hello, my name is ClintonJones, and I am the Director of Pediatric Perfusion for Benioff Children's Hospitals at the University of California in San Francisco, California, in the United States of America. I would like to extend my most sincere appreciation to Mr. Pillai and the rest of the organizing committee of the Indian Society of Extracorporeal Technology for today's invitation to speak with you on Ecmo in neonates with complex congenital cardiac pathologies. I have no financial sponsorships to disclose. Today, I would like to provide a brief overview of our cardiac Ecmo program at UCSF, then give a general overview of the current trends in ELSO data, and then discuss the challenges faced with complex cardiac physiologies. I'd also like to discuss the challenges of anticoagulating a fresh post-op baby. And in conclusion, we can discuss some strategies for improving Ecmo in this setting. Here at UCSF, I have the distinct honor to work with Dr. Mohan Reddy, who performs open heart surgery on some of the smallest premature and low birth weight neonates in the world. While working on very small children is a challenge in the operating room, it is also a major challenge to manage if they're on Ecmo. This is a great review article that describes our staffing model here at UCSF. The surgeons cannulate, the perfusionists assemble the Ecmo and manage initiation and discontinuation. We have nurse specialists trained to set the Ecmo run, and the ICU intensivists are responsible for managing the medical care of the patient. Here's a picture of a traditional roller pump Ecmo circuit. We are all familiar with this and also the footprint it occupies. Here's a picture of the ECPR circuit that we designed back in 2001. It had a prime volume of 240 mLs, and we could expect about 72 hours of service before we started seeing plasma leak across the hollow fiber oxygenator. We kept this circuit primed with Plasmalite in our PCICU and had a 12-step protocol so the intensivists could have the circuit ready, and sometimes even have the patient on ECLS before the perfusionists even arrived. 2003 was our busiest ECPR we've ever had. 35 patients needed ECPR, and the median time from arrest to initiation of therapy was 22 minutes. This evolved into our current ECPR/Ecmo circuit. It primes with 280 mLs of Plasmalite, and we keep it primed 24/7 in our PCICU. We use the CardioHelp for all of our Ecmo at UCSF, in the CVICU and the PICU as well. We use the 5.0 HLS for any child requiring 1/4 inch cannulas, and a 7.0 for anyone who requires 3/8 inch connection cannulas. The reason I chose this picture, though, was to highlight the feature that I believe sets this system above all others. As you can see from the red arrows, there are 4 exits from the centrifugal pump, aimed towards the corners of the oxygenator. We feel this prevents stagnant blood and clot formation in the corners of the oxygenator. We rinse out and take pictures of every oxygenator we use for every patient on Ecmo. And this was a very typical finding in our oxygenators, especially in the corners. This is now a very common finding for us upon rinse out. This was a 5.0 circuit that was used on a VV run for a 3.2 kilo patient using the same circuit for a 28-day run. Here's the modification that we make to the CardioHelp to make it work for pediatric Ecmo. This is the tubing set that we currently use at UCSF. We currently cut the tubing off of the CardioHelp disposable and attach our own tubing directly. While it is coated just like the tubing we're throwing away, This tubing is tapered from 3/8 to 1/4 inch, which removes all connectors from the circuit. We have found the reduction in connectors to be extremely valuable to prevent thrombus formation. Also, we have pigtails that we attach with stopcocks attached to the 3 lure ports on the CardioHelp. These 3 are the only access that we have in our circuit, and it is fairly common for us to attach the CVVH as seen in this picture. We have also instituted a few simple changes to our practice to help extend the life of our circuits. We now use toothless clamps for all of our Ecmo and VAD circuits. We have found in the past that the locations that we have clamped, for example like when we're bridging, were the locations that then fibrin started to form later on. We have also instituted the practice of moving the flow probe daily, just as you would if you had a patient on the Centromag. So quickly, I also wanted to share some data from ELSO. As you can see from this graph, there has been a constant increase in neonatal Ecmo runs since 1990. However, it appears that the numbers have peaked in 2014 and now are holding steady or even trending down. As you can see here, the most common diagnosis requiring Ecmo is a congenital defect. And when looking at risk factors for postcardiotomy Ecmo, we're all familiar with these. As you can see, it's the youngest, the smallest, and the sickest patients who have the highest risk of going on Ecmo after surgery. I included this slide because I thought it was interesting that the centers that tried at all costs to avoid Ecmo, there was no statistical significance in survival, whether they went on Ecmo in the OR or the ICU. However, if you look at the 2 sites that trended towards initiating Ecmo in the controlled setting of the OR, you did see significantly better outcomes for those patients. And I included this slide just to illustrate the fact that even with the best care, the survival rates of this cohort are just not great. So they're looking at the challenging anatomy of neonates. There are many anatomical challenges which limit our ability to provide optimal Ecmo support. One of the most common challenges for us in our institution is a patient who has received a bidirectional Glenn shunt. But there are also many other structural anomalies that need critical analysis by the team to prepare for successful cannulation and being able to support the patient on Ecmo. For cervical cannulation, we do place cerebral and somatic NIRS probes on all of our patients. We have one recorded case of a patient who was being cannulated cervically that had lost unknown to us, had lost the left carotid. When the cannula was inserted into the right carotid, the NIRS immediately plummeted. And with that information, we changed our cannulation strategy and avoided what would have been a certain neurologic catastrophe. But femoral cannulation is also not without risk. One common situation is not being able to fully support a patient that you're putting on Ecmo who has little or no existing lung function. Any blood that's being ejected from the heart is deoxygenated, and you will have what we call north-south phenomenon, where the lower body is fully oxygenated while the coronary arteries and head vessels are seeing deoxygenated blood. Having a right radial art line to be able to draw gases, or at the very least a pulse ox on the right finger, is very helpful in these situations. In marked case, it's not uncommon to have dual arterial cannulas, one in the femoral artery and one in the carotid artery, to avoid this north-south phenomenon. And it is also not uncommon for us to add an arterial catheter to provide distal perfusion to the cannulated leg. We usually use a Cordis catheter for this situation. As we all know, the biggest challenge in neonatal extracorporeal support is a postcardiotomy patient. How do you balance hemostasis with adequate anticoagulation? We struggle mightily with that. Do you use heparin or bivalirudin for anticoagulation? How do you assess that anticoagulation? Do you use ACT, PTT, heparin concentration, antithrombin levels? At UCSF, we currently use heparin for our Ecmos and bivalirudin for our VADs. At UCSF, we currently aim for a heparin level in the range of 0.3 to 0.6. We administer thrombate if AT levels fall below 75%. We like our ACTs to be in the normal range of 180 to 220, the gold standard, but on the lower end if the patient is bleeding. The most important thing that we assess over and over is to ensure that the anticoagulation parameters are all correct before correcting platelet or fibrinogen levels. As we've seen often, if not, the next ACT will be 120 seconds and you've just started the ball rolling on a consumptive coagulopathy. So there are many factors that can help make neonatal ECMO safer looking to the future. Smaller circuits that have less stagnation and that are more biocompatible will be very important. And there's a lot of work being done on that. Also, continuing to look for better and safer methods to anticoagulate and to test the effects of that anticoagulation will also help improve our ability to provide a safe ECMO to our patients. Also, improvements to blood propulsion are helping to improve ECMO outcomes, such as seen with magnetically levitated centrifugal pumps. Again, thank you for the opportunity to present today. It has been my pleasure.